Hello, my name is Angela Schulz. I'm a child neurologist in Hamburg, Germany, and I'm very pleased to give you a presentation on CLN3 disease with a focus on clinical management and current guidelines. CLN3 disease is also called neuronal ceroid lipofuscinosis type 3. It's part of a group of neurodegenerative lysosomal storage disorders, and it's caused by mutations in the CLN3 gene. There are more than 40 mutations described, but the majority of patients are homozygous for the 1kb deletion, which leads to the loss of exon 7 and 8. If you look at the clinical progression of CLN3 disease, the first symptom occurs between the age of 4 to 6 years with visual loss. This is rapidly followed at the age of 7 to 8 years with first signs of cognitive decline, then around 10 to 12 years epileptic seizures start, followed by psychomotor decline, and then the patients become completely bedridden by the age of 18 to 20 years. Life expectancy is severely decreased, and early death around the ages of 22 to 30 years unfortunately happens often in our patients. In order to provide optimal disease management to our patients, we really need to address a variety of different areas. There are symptoms such as epileptic seizures, movement disorders, speech problems, nutritional problems, secretion, respiratory management is important. Sleep disturbances are often a frequent problem. Of course, there's vision loss in these patients. In later stages of disease, pain and other causes of distress are a big problem. Social, educational, and behavioral interventions are necessary, and of course, family support and resources. I will focus on a few of those areas here today. Let's start with the vision loss, which is one of the first symptoms at the age of 5 to 7 years. It's important once vision loss occurs to really consider special schools, special teachers, special teaching devices. Many children profit from undergoing Braille training, which helps them to still read and write with their peers. Mobility aids and orientation training is important. Also, even though a child might already be completely blind, you should still consider to have regular ophthalmology follow-ups being taken care of, because sometimes we see in our patients in later stages cataract and other ophthalmic problems occurring. Also, we should educate our families and patients on other visual impairment support strategies, such as special devices that can be obtained through healthcare system. It's important that in the beginning, the visual impairment does not necessarily have such a severe impact on the children's everyday life. So when it starts at the age of 4 to 6 years, as you see here in this graph, the visual impairment is severe. However, it takes a year or two until really everyday life is very much affected. And then once the children are completely blind, of course, they really, really suffer from this visual impairment. The visual impairment also has a very serious effect on the education. We think that early education in a school that provides special teachers for the blind or a special school for the blind should really be thought about. There is in Europe here freely available a book on the education of patients with CLN3 disease. You see here the link where it can be downloaded for free. Also, being able to still play games, listen to music, interact with others, and have a lot of fun is important for these children. And you see here in the pictures a couple of examples of games that can be played even by patients with severely impaired vision function. After the vision loss, the next symptom we frequently see is problem with the language. Usually the first signs of a speech problem could be that patients would forget certain words, they would start to mumble, they would use only short sentences, have limited vocabulary. Also, stuttering is a common problem. I think it's important to keep in mind that language comprehension is usually preserved much longer than the language expression. So our children understand what we're telling them, but they cannot really answer. So it's important to early implement tactile communication boards or other communication devices that help the children to express their wishes and needs. Seizures are another important problem in this disease. Grand mal seizures, tonic-clonic seizures are most common in CLN3 disease. Seizures can range from well-controlled in early disease stages under antiepileptic drugs up to being completely therapy refractory. And we have to keep this in mind because the goals for treatment are really to maintain quality of life, to control the seizures while still balancing the side effects. And a complete seizure control and being completely seizure-free is often not realistic. Management of epilepsy involves antiepileptic drugs. The ones that we frequently use in CLN3 patients are valproic acid, lamotrigine, phenobarbital, CBD, and in some cases also levetiracetam, which can be very efficacious. However, it can trigger very severe behavioral problems. You should really avoid carbamazepine, phenytoin, topiramate because this has bad side effects in CLN3 patients and aggravates the myoclonus. Patients also suffer from a movement disorder phenotype, which involves dystonia, myoclonus, dyskinesia, posturing, ataxia, Parkinsonism, and tremor. Also here, it's important to really try to maintain quality of life, to prevent pain and maintain function as best as possible. Medications that we would recommend here are pregabalin, chloral hydrate, benzodiazepine, CBD, and in some cases also levodopa, carbidopa. It's important to keep patients moving, be it on a bicycle, using hippotherapy like horseback riding, and in later disease stages using standing devices. Medications specifically for dystonia that we use are trihexyphenidyl, tetrabenazine, and baclofen. Psychiatric problems can be very, very severe in CLN3 patients in some disease stages. Some might be triggered by frustration, depression, aggression as part of the dementia, and some might really be a full organic psychosyndrome involving fear, panic, and even hallucinations, and this is really, really an emergency case. However, neuroleptic drugs that are usually used for these kind of symptoms should be avoided if possible because they have a high risk of extrapyramidal symptoms in CLN3 patients. Other problems involve gastrointestinal issues, secretion, and constipation. In order to prevent constipation, we recommend high-fiber foods, macrogol, and physical therapies. Dysphagia is a problem in later disease stages and should be managed by thickening of the food, a gastric tube placement if necessary. There are also some kind of leucopedic therapies like Castillo Morales swallowing therapies that help with that. If a gastric tube is being placed and the patient is being fed with tube fed formula, we clearly recommend to avoid the high caloric formula with 1.5 kilocalorie per ml because they are not well tolerated. Secretion management is also an issue in later disease stages. Secretion can be managed using corn silk tea, scopoderm plasters, botulinum toxin injections in the glandula parotis, glycopyrronium, and positioning. Pain and distress are a big problem in later disease stages, and pain can really be caused by a million of different things. You could have pain due to tooth pain, you could have abdominal pain, you can have pain due to skin problems with pressure lesions. Myoclonus can cause pain, dystonia, wrong medication, psychosis, fractures, dislocations of joints. All these things can really cause severe pain. One of the most frequent causes really for pain is abdominal pain. Our patients suffer from constipation, as already mentioned. They suffer from reflux, but sometimes some of the antiepileptic drugs can cause gallbladder stones and pancreatitis. Urinary tract infections are also not uncommon in our patients, and also you have to think about other pain causes like a testicular torsion of an ovarian cyst or hernia. All in all, I think it's very, very important to always search for the cause of pain and distress. It's important to ask the patients and the family regularly about the pain. Believe the family, the patient, especially the parents, when they say they think their child has pain. Choose pain control options that are appropriate for the patient, for the family. And also it's important to really empower the patients and the families to really control this pain and the cause for the pain. I think this is the most important part. Sometimes classic pain medication does not really work, but rather we have to choose pain medications or medications that treat the underlying cause, like dystonia, myoclonus, constipation, or reflux. There are many things to consider in the management of CLN3 disease, and management might differ from center to center or country to country. Even more so, it's very important to find an agreement on the best management guidelines. Very recently, actually only a few days ago, an international guideline recommendation for CLN3 disease has been published and is now available online. This guideline comprises the agreement of 39 international experts from eight different specialties. It used the modified Delphi consensus process and contains 53 recommendations across 11 clinical specialties, and I highly recommend this to you. If you have any additional question about your patient, about your child, do not hesitate to contact us in the NCL Specialty Clinic here in Hamburg, Germany. You find our phone number, our email address, and also our emergency phone number here. And I thank you for your attention.